Well, thank you everybody for coming. We really enjoy doing these presentations. We do probably 4 of these a year. This is part of what we used to call our community education series. We did it for a lot of years, and then COVID came along and we stopped doing it. We used to do this over the library, and we just picked back up doing it here the last couple of years. So kind of look out for more coming. This evening, we're going to be talking about a topic that's near and dear to my heart, one of my specialties. These gentlemen here also treat this. That's what I'm going to call persistent low back pain. So the title is Understanding Persistent Low Back Pain. What are some physical therapy interventions and self-help tips? My name's David Coletta. I am the founder of Excel Physical Therapy. I'm a physical therapist. I'm a certified orthopedic manual therapist and a fellow of the American Academy of Manual Physical Therapy. And I've been a PT for about 28 years. We also have Taylor Reick, who's presenting this evening. He's an OCS and a COMT, and he is one of our managers here. And then finally, we have Evan Telford, who's a PT, who's in residency with our clinic right now. And like I said, we all treat low back pain. So what are our learning objectives tonight? What are we going to go over? And by the way, this will probably run about an hour. So settle in. Hopefully you can stay that long. There'll be questions at the end, but you can also ask questions anytime. So I'm a big believer, if something isn't clear, just raise your hand and we can go over it. So we would like to gain an appreciation for the basic anatomy of the lumbar spine, pelvis, and associated muscles. We want to learn how persistent low back pain and associated conditions develop. And we want to understand, what does a detailed physical therapy evaluation involve and why is it important? How can physical therapy treat low back pain? And then some basic self-help techniques for persistent low back pain. So getting a little personal here. This is my spine. So my low back journey, and the reason I'm even standing before you here today is because I injured my low back when I was probably in my early 20s. And when I did injure my back, this is what happened to my low back. So this little divot out of the third vertebra of the spine here is called a Schmorl's node. These are the vertebra of the lumbar spine, and then we have the discs that sit in between. So I went from being a competitive bike racer to a competitive volleyball player, very different positions. So I went from being on a bicycle like this for a lot of years to doing a lot of this, and my back didn't like it. I was pretty much stuck into that flexed position. I think I talked to a gentleman earlier about being very stiff, right? So your my body wasn't able to do that. And what ends up happening is if you become too stiff, something fails. What failed on me was the end plate right here. So if you look at the anatomy of the spine, we're going to go over this a little bit more in a minute. But you have vertebra, disc in between, and the disc is attached to the vertebra through what we call end plates. And those end plates are kind of hard, okay? So they kind of protect the vertebra. But if you have a bad enough disc injury, like you see right here, that disc material will actually bust through the end plate and go into the vertebra and actually, over time, eat away the vertebra and make the vertebra more unstable. So that's what happened to me, and I was in a great deal of pain in my early 20s. I didn't have any leg pain or anything like that. It was just lots and lots of low back pain. By the way, this is my mid-back. I felt pain all the way down into here, and I still have some degree of pain at this point in my life. This is my most recent MRI. I have several, but this is the most recent. The thing I want to make the point on here is this is a bit of a nasty spine here. It's not the worst. I've seen worse for sure. The other thing is I have lost some of the curvature in my low back. There should be more what we call lordosis right here. But I'm still able to do what I want to do, and I'm still able to do things like competing in bike racing and cross-country skiing. And that's the important thing to note is, even with having persistent low back pain, it's not a death knell for your function. You just need to do things a little differently and have a different perspective on what you're doing. Do I still have some low back pain? I do. But I know how to manage it, I know how to get around it, and I can live just fine with it. So let's look briefly at the spine itself. So we have basically a cervical spine, a thoracic spine, a lumbar spine, and then the sacrum down below. So there are 7 cervical vertebrae. Then there are 12 thoracic vertebrae. These are all the vertebrae that are associated with your ribs. And then there is a lumbar vertebra here, 5 of those, and then the sacrum into the coccyx. This is all fused. So all of these vertebrae here have discs in between, except for between C1 and C2. It's a special place. But you'll also note that there's a curvature. If this is a lateral view, there's a certain curvature that should be here from anterior to posterior. This is called a lordosis, or sorry, yeah, this is a lordosis, an anterior curvature. This is a kyphosis, and back to a lordosis. So when I was saying my spine was a little straight, I had lost a little bit of that lordosis. Okay, if we go into actually looking at what one segment in the lumbar spine, this is a typical lumbar vertebra. We have, again, our segment, motion segment is what we call this. So a motion segment in the spine is a vertebra with a vertebra and then a disc in between, okay? And so what we're gonna do here is we're just gonna take a slice through and we're gonna go to this right here. And what we can see is we have this nice disc that's nice and healthy. We'll look at some unhealthy discs here in a minute. But this is a healthy disc that has a beautiful structure of having this outer portion called the annulus fibrosus. So that is a more stiff structure that retains the nucleus, which is more fluid inside. And we talk about a normal fluid nucleus pulposus on the inside of a disc. It's like the consistency of toothpaste, okay? So it's not, super fluid, but it does move with the spine moving. And then in the center here, we have the spinal canal with the spinal cord. Now, this is a little bit incorrect. In the lumbar spine, we actually don't have the spinal cord. We have what's called the cauda equina. So the spinal cord, as it comes down the whole spine, terminates at about L2, and then it becomes these skinnier nerves that go down the spinal canal, and then they all bust out little canals on the side. Right here, the intervertebral foramen, these nerves go out to your lower extremities to give you sensation, function, pain sensation, those type of things. And then we have the facet joints. These are the joints right here, right through right there. So you have one vertebra that meets the vertebra below on the right and left side with a facet joint. And that's how we basically get motion with this motion segment. The disc function is to take compression, but it's also to give us motion. Why don't we just have solid structures in between our entire spine? Because we need to move, right? The spine needs to move. And so the motion is accomplished here with the disc and with the facet joints. And again, where you have motion, things can go badly, or not go badly. They can basically get degenerated. So your facet joints can become degenerated, your disc can become degenerated. Okay, if we pop down to so again, this is the lumbar spine. If we go down lower, we're gonna get down into the pelvis. So the pelvis is oftentimes associated with low back pain. And I'm sure you guys have heard of the SI joint. It's a popular part of the spine to talk about. So where you see these arrows, this is a front view of the pelvis. And here's an arrow of the SI joint. It's where the sacrum meets the ilium, so sacroiliac joint. And there's the back view. But then if you look at what's on top of that, there are a lot of very strong ligaments, both on the front and the back of the SI joint. Really the strongest ligaments in the body are there. So there's a lot of debate on whether or not the SI joint moves. It does move. It's a synovial joint. So any synovial joint in any part of your body means there's motion there. There's not a lot of motion, but there's some motion here, okay? All right, I love this image here. So this is really important because these are a lot of time, the things that we can work on is our strength, right? So if our facet joints degenerate, if our discs start to degenerate, what can we actually do to make ourselves better? This, right? So this is the outer view here of the abdominal region from the front view, okay? So we have obviously six-pack right here. You have your rectus abdominis. You have your oblique muscles on the sides, internal and external. And then on top, you have your diaphragm. It really doesn't show a picture of this, but I'm going to show you a much better video of the diaphragm here in a second. And on the bottom, you have your pelvic floor. So it's really a fully encapsulated thing of your lower trunk. That's where your core is. Now, if we take this red line and we just slice right through about L3, we're going to see this right here. So this is just a beautiful view of this. Right here is the bone. This is a view of a vertebra, and just look at how much muscle surrounds that vertebra. And why is that muscle there? It's there to stabilize the spine. It's there to move the spine. It's there to protect the spine, okay? So if these muscles here, by the way, if anybody's heard of the psoas, we're going to talk about that here in a minute. This is the psoas major on the right and left. These are the multifidi muscles, and over here on either side here are the erector spinae muscles. So these are the deep muscles that actually sit on the spine from the back, or from the back and the front. And then again, this is all your abdominal contents, your intestines, all your abdominal contents, your stomach. And then you have your rectus abdominis here. And look at all these nice layers of muscles that are kind of almost like rings around your core. Your very deepest is your transversus abdominis. And that transversus abdominis comes all the way around through fascial planes and attaches to the bone here, to the transverse process. So again, this is what we can work on a lot of times, is that muscle. It's really interesting to look at MRIs. If you guys have MRIs, if you look at the cross sections of the MRI where they actually take these little slices, you can actually see these muscles will become smaller, and they'll actually have fatty infiltrate. They'll have lots of white in there, which shouldn't be there, right? So good healthy muscle is going to be kind of dark. If you see all this white kind of mixed in, that means that muscle's not working great anymore. Okay, and you might even notice that one side has that, the other side doesn't. One side's smaller, one side's bigger. These are the things that sometimes we see on MRIs with people who've had low back pain for a while. Okay, the psoas major, the muscle that I'm actually very interested in. I think it's a very important player in terms of low back pain and stabilization. So this is the psoas major, this is the iliacus. Together, they're called the iliopsoas, right? And they come down and they attach in the front of the femur. So this muscle here, look at all those vast attachments to the spine itself. So if you have a muscle that attaches to the spine, it has to both control and stabilize that spine. So that's one of the functions of the psoas. It's also a hip flexor because it's attached to the hip. But also what I find in a lot of patients is it can become tight. We are going to show you an exercise at the very end because we're just going to show you a few. One is a hip flexor stretch. When your psoas becomes tight, it pulls on your spine in a way that can be painful and be problematic, okay? And then this is a view from the back of the lumbar multifidus. This is a muscle that goes all the way up your spine. It gets a lot bigger in the lumbar spine. And again, this is one of those muscles that we really need to stabilize and strengthen. As well as I do strengthen the psoas on my patients as well. Some of you here that I know do that. All right. Another muscle I am very, very interested in and I've taken a deep dive in is the diaphragm. So diaphragm is the major muscle of breathing, right? It sits on, so if you see here, everything below here is your abdominal contents. Below the muscle, everything above is your lungs, okay? So basically your lungs at the bottom are glued to your diaphragm so that when your diaphragm descends and contracts, it actually pulls air into your lungs to fill up your lungs. Okay, and at the same time, these ribs will spread out, okay? So I want to go to a quick video that I am very fond of and I found recently. I just think it's such a beautiful thing. Okay, so look at that diaphragm. And this is in its relaxed state right here. As it contracts, it will descend, okay? You see it descending, and it spreads out the ribs all the way around. If you see here, these little slips that are coming down and attaching to the spine, those are called crurae. And so there are actual attachments of the diaphragm to the spine. So a diaphragm can become tight. If a diaphragm becomes tight, it's not going to allow this motion that you see of the lower rib cage, and the lower rib cage can become tight as well. And as well as it can kind of hang on to the spine and be problematic. So I find myself a lot of times releasing the diaphragm. Another thing we're going to go over here at the very end is how to breathe through the diaphragm. That's one of my treatments for low back pain, is actually breathing. But that is just a beautiful visual animation of what that looks like. Okay. Back to this. Okay, so pelvic floor. If we look down into the spine, and we're looking straight down this way, and the very bottom is going to be your pelvic floor, okay? So your pelvic floor above that will be your bladder and other organs that sit there. So we have the diaphragm on the top, creating the top of the core. We have the pelvic floor on the bottom, and then we have everything in between that I showed you here, and then those deep muscles that attach. That is your core. Some people will say the hip is the core, the hips muscles are core as well, and I do believe that. But we're going to go into a second here, what's called the POP-CAN theory of spinal stabilization, which I really appreciate. And that is right here. So I can't give anybody credit for this because when I went and looked it up, it's like different minds coming together for a topic, and eventually it just becomes common knowledge, and it just makes a lot of sense. So I can't say anybody came up with this in particular, but when we think about this, think about a pop can, and think about that pop can having walls all the way around. It has a top, it has a bottom, okay? Same thing with your core, okay? We have the walls going around, including these multifidi muscles and the psoas, everything kind of going around center. And then on the top, we have that diaphragm, and the bottom, we have the pelvic floor. So when everything's working like it should in terms of the muscles, we have good stability. We have good intra-abdominal pressure and rigidity in a good way, right? So when we go pick something up, we need rigidity of the spine. We need the spine to be stable. If something is giving and not creating stability, we can more easily injure some of those structures of our low back. Okay, so here's what happens when something goes wrong. So let's say the top of the pop can, the diaphragm's not working correctly, and we'll talk a little bit about how that might happen. You lose that diaphragm on top, you lose some of that rigidity, and therefore you could develop some kind of injury into your lumbar spine, and it could become more degenerative easier. Any questions about that at all? Okay. So what symptoms develop? Obviously, low back pain itself, persistent low back pain. The American Pain Society defines persistent low back pain as lasting 12 weeks or longer. A 2016 study revealed that persistent low back pain was the leading cause of years lived with disability in America. That's a pretty profound statement. So bottom line, this is very common. So a 2016 study revealed that persistent low back pain was the leading cause of years lived with disability in America. So unable to do the things that you want to do. Probably not like major disability, like being in a wheelchair or something like that, but not able to do your sport or not able to maybe clean your house or something like that. Another thing that can happen is you can get pain from this area reflected down into the glutes, reflected down into the entire pelvic region. So this is associated both with low back structures and with pelvic structures. And then obviously, and maybe some of you have experienced this, you can develop symptoms into your legs, okay? Pain, numbness, tingling, weakness, any of those things can happen into your legs, either one leg or both legs. And that can be coming from that low back. Remember those nerves that kind of exit out of the spine that we showed earlier? Those can become compromised, and those give these things, sensation, pain sensation, touch sensation, as well as strength. And if those are compromised, it almost kind of is like kinking off a garden hose type of a situation. So how do problems develop? We've talked about this a little bit. So we can basically lose that muscular stability for whatever reason. So some part of the pop can, quote unquote, goes wrong. And this can make the lumbar spine structures, those discs, those facet joints, more vulnerable. We can just have general wear and tear of the low back, right? Just life. I can't tell you, living here in Montana, how many times people have told me, like, what have you done for your life? Well, I've worked on a farm as a kid and worked on a farm as an adult, and basically my body was a machine, and I was just working, and maybe that over time caused some kind of degeneration and breakdown that was maybe a little more advanced than it should have been. And then downstream problems. So I like to explain to patients that a sprained ankle chronically can lead to low back pain. So I'll get some patients that'll come in, and the first thing I have anybody do before I evaluate them is walk. I don't care if it's a neck, a low back pain, a hip, whatever. And let's say I have a patient who's walking and they have a limp and they're not following through with this leg. Well, the ankle, because it was sprained so many times and not treated well, not rehabbed well, ends up being stiff. And now you don't have that follow through the ankle joint, and you tend to put too much hip extension on and too much lumbar extension, and you do that again and again and again with running or walking, and eventually something goes wrong up here again because you're putting too much stress into that part of the body. And then obviously trauma. And again, some of you might have had this. We live in Montana, we have ice, we have snow, we slipped, we fall, fly through the air, we land on our butt, whatever. But we have motor vehicle accidents, pregnancy can be traumatic, birth trauma, those type of things. Another thing is scoliosis. So we talked earlier about this kind of looking at me from the side and this side-to-side curvature that's normal. If you look for me from behind, and you looked at my spine, there shouldn't be any side-to-side curvature. If you do have that side-to-side curvature, then that's a scoliosis, and that is going to create imbalance in a way, and it's going to, what your body's going to do is eventually it's going to keep your eyes horizontal, and everything below is going to do kind of a twisting type of a thing, and that can put excessive wear and tear on those facet joints. It could put excessive wear and tear on the discs. And then finally, just, sorry, that's in the way. Oops. Just normal arthritis in the low back, right? So again, as we age, our joints are going to tend to get breakdown, and those joints can develop loss of cartilage. So those facet joints I talked about earlier, those can lose cartilage, and they can hurt after a while. They can become inflamed. I like arthrosis. That means natural breakdown of the joints. Arthritis means you have an itis. You have an inflamed arthrosis. And at that point, it becomes painful. Again, it can be normal, but some people tend to have more advanced because of their history or because of their age, or sometimes just because of genetics. I've seen families where their spines degenerate quicker for whatever reason. Okay, talking about those disc problems. So we looked earlier, and there's another nice healthy disc right here. So we have the disc here with the annulus, and we have those nerves. So these are 3 levels of having disc problems. This is the least, and we go to the most. So you can have a disc protrusion where that nucleus kind of starts to push through the walls and cause a bulge. That in itself can be painful, even if it doesn't push on this nerve, because the outer annulus is innervated, and if it becomes inflamed, it will hurt and give you low back pain. But when it starts pushing on this nerve, that nerve itself, that little irritated thing right there, will actually start to cause pain, maybe numbness, maybe tingling, maybe weakness down that leg. And then we have further that is happening here with what's called an extrusion. Okay, so it's busted through those annular walls, and it's outside. And then if we have a sequestration, it's actually detached from that nucleus, and it's in the space here, kind of floating around, but still irritating that nerve. And by the way, any 3 of these is an inflammatory event, and it doesn't actually have to be mechanically pushing on that nerve. Just having inflammation in that area can irritate the nerve and cause pain shooting down your leg. 100%. Yes, that is why you would get an MRI. You'd want to see those discs. You want to see the health of those nerves coming out the side. Yeah, that's a great question. Okay, so if we just look at the degeneration of the spine itself, remember I told you earlier how my spine was a little straighter, maybe not as straight as this, but when that starts to happen, you start to see loss of height of those discs, okay? So they start to degenerate, kind of almost naturally, okay? That's gonna increase, this kind of shows red, red, red here. As this decreases in height compared to a normal spine right here, these facet joints start to see weight bearing, and they start to see pressures that shouldn't be there. And after a while, that can create arthritis, and it can create pain, okay? So if any of you have been, diagnosed with degenerative disc disease, sounds awful. It kind of sounds like a disease, but basically you're losing that disc height, and that disc height is causing pressure here. Not only that, but these little holes right here on the sides, these intervertebral foramen, those will come closer together and create stenosis. Has anybody heard of stenosis before? Right? So you can have what's called lateral canal stenosis, and that's on those nerves going out the side. And you can have central canal stenosis, and that's that central area I was talking about earlier. I'm sorry? Yes, and I need to be repeating these questions because I'm supposed to do this for the recording. It can make you shorter. That's really the reason that we get shorter. We lose some of the disc height over time, and our whole spine. We showed you earlier how many discs are there. You add that up, disc by disc by disc, and it will actually make you lose height. Does that answer your question? Yep. So let's go back to that diaphragm, okay? So how can the diaphragm go bad? I think this is important to note. So stress, right? So if we start breathing differently and stop using our diaphragm down here where relaxed breathing happens, we can start to become upper chest breathers, which will probably cause neck pain as well, but it changes how the diaphragm works. Now the diaphragm's not going through a full range of motion like I showed you in that video. It's going through a shorter range of motion, and now we're stiffening all around this area in a bad way in the thoracic spine and ribs, And now we're going to end up putting more pressure on the lumbar spine and maybe wear and tear in the lumbar spine that doesn't need to be there. So stress as well. I know this looks comical, this guy's sitting here, but I was just in the airport last night and I see a lot of this. You know, I see some pretty awful postures. Sometimes my patients, I ask them to show me, like, what do you look like when you're at the computer? And they'll show me just some crazy things. When you do this, you are putting compression on your diaphragm so it can't go through a full range of motion. And after a while, you can stop breathing normally just because of that. So I think next year I'm actually going to do a presentation just on posture, but just rest assured, posture can be a problem for a lot of reasons, but it can change the way that we breathe. And then if we change the way we use your diaphragm, the top of the pop can is an issue. Yes, sir. That's a great question. So is there effect with the breathing, whether you're a mouth breather or a nose breather? I think generally, in a lot of ways, there's a big effect. So we generally want to be nose breathers. When we breathe through our nose, we tend to use our diaphragm more. So that's one thing, right? But there's all kinds of other reasons why you might not, that we're not even going to talk about tonight, that we wouldn't want to breathe through our mouth, because that's kind of a fashionable thing nowadays, right? Like, let's use the mouth tape, let's breathe through our nose. I think it actually is a really good thing. Why do you ask? Is he using mouth tape? Okay. Yeah. Yeah. There's a certain point where you have to pop your mouth open. There's a certain point where you have to pop your mouth open when you're exercising, or you can't get that amount of air in. But there's a lot of really high-level athletes that try to go as far as they can with just breathing through their nose before they have to go there. So I think a lot of people, even when they're doing light exercise, could be breathing through their nose, but they start breathing through their mouth early. But yeah, you should tell your son to look into the mouth tape, because that's interesting. It's not like duct tape, although I guess you could use duct tape. It's just a little more brutal. There's nicer to your body mouth tape that you can use that makes your mouth this proprioceptively. It gives you the sensation that you want to keep your mouth closed, but you can bust through it if you want. And people will tend to use that at night, so they become more nose breathers. So to answer your question in terms of this low back presentation, yes, because your diaphragm is more accessed, used better with nose breathing, you want to be more of a nose breather. So pelvic floor dysfunction, like I said, I was in an airport yesterday, but yesterday during the day, I was at a job fair, or career fair at the University of Utah, and I was standing next to, my table was next to a lady that was a pelvic floor specialist, and I was talking to her about my presentation, and she said, you know, studies are coming out now showing that 95% of all people, not just females, 95% of all people that have low back pain have some level of pelvic floor problem. Either that pelvic floor is weak or that pelvic floor is tight. Now, the amount of people that takes in a lot of people, because we talked about the percentage of, so probably a lot of people here that are sitting here, including myself, have some level of our pelvic floor not working correctly. Now, most men won't go in for pelvic floor therapy. A couple do, but mostly it seems to be in fact, the whole field used to be called women's health. They've changed it to pelvic health because now that includes men. But again, that's that bottom of the pop can. If that's not working correctly, that's going to cause problems. In general, there are women PTs that are the people treating this. I don't know if I know any men PTs that treat this because there's somewhat of an internal exam involved. But we do have one physical therapist here that's been trained in this, and there's several others around the town that do that. So maybe something that you haven't thought about, could your pelvic floor, it's giving you problems maybe with urination, like you're having difficulty with holding it, difficulty with urge, difficulty with losing your bladder, pain with sex for women, that could be a sign. Also bladder can also be an issue with pelvic floor. It doesn't have to be just urinary issues. It could be, bowel issues, could be bowel issues as well. So I just wanted to kind of pique your interest on that. If you do think you have an issue here, try to see a pelvic floor specialist, which again, we do have one of here at our clinic, Kylie. She's marvelous. Now, this is a really interesting topic. So probably nobody here came tonight thinking that the source of your low back pain is your brain, but it is. The source of any of your pain is your brain, right? So again, chronic or persistent low back pain is defined as lasting 3 to 6 months or more. There is a humongous body of evidence coming out now that the longer pain exists in your body in a certain area, the more prevalent it's going to be for you. So the more receptive, this is almost a cruel joke, right? My back is killing me. The longer that it's around, my brain becomes almost more receptive to it, where I feel it more easily. It doesn't take as much to get my back to feel pain. Not only will this kind of chronic pain increase your receptiveness to low back pain, it'll increase your receptiveness to any pain. So it lowers your pain thresholds. Generally, we want to have higher pain thresholds so that we don't hurt as much, although pain does have a function to keep us from danger. It can become dysfunctional. We can develop kind of chronic pain syndromes where we have the opening up of those pathways of pain to our brain to sense more pain, and then hypersensitization of our bodies to pain. So what causes that, right? So first of all, just the pain being there with some event, but undoubtedly, a lot of times there's excessive levels of stress. How many of us in this world have excessive levels of stress? You know, our kids, our work, whatever. Stress is hitting us from all sides. So that can actually make us more prone to chronic back pain that's associated with the brain. So negative thoughts or emotions associated with our low back pain. I'm going to throw my dad under the bus here for a second. So love my dad, but he's a guy that's had low back pain probably for 30 years. And he is deathly afraid of his back. So I've seen his MRIs, I know what's going on with him, but he is so afraid of his back, he will do almost nothing. And he moves like he's like a toy soldier. He barely move his body. And when he has any sensation of low back pain, he'll almost scream out. Like he's so afraid of his back. And I try to kind of work with him to understand if you just changed your perception of what your back, pain doesn't always need to be harm. It could just be a signal to your body to do something a little differently. So a lot of times, the way that we even think about our pain can make it more painful for us and more persistent. So I've spent some of you are my patients in here, probably get sick of me talking to you about how you think about your pain and that kind of thing. But being more positive about it and having a more positive outlook really does help. And again, we might even do a whole presentation here that's just about chronic pain and how to deal with chronic pain. Okay, so ultimately, what's the source of my low back pain? I've gone over a lot of things. Your brain, your psoas, the muscles, the facet joints, the discs, the nerves, the SI joint, the pelvic floor. There's all kinds of ideas. There's many qualities or many possibilities. And the point I want to make is when you see a good physical therapist, they're going to be able to kind of wade through those things and see those things that make sense that are causing your issues. It's not the same for everybody. But, and therefore, there's not the same kind of routine for everybody. There are some things that most people get, but generally, people are going to get customized things for their specific problem. From there, I am going to hand it off to Taylor to go into what PT does.
All right, I'm Taylor. I know some of you have been my patients, so big thing I'm going over here is what PT can do for you. So in the PT world, we have examination and evaluation. Examination is what you're used to. We check out your range of motion, your strength, everything you're seeing that first day. Then the evaluation is more of like our thought process. So what do we think is going on? What is our plan going forward? So a big component, and I didn't really realize this when I was a new grad, is how important a really detailed history is. When you're a new grad, you're just trying to get through the history so you can check out everything that you want to get done that day. But as I've grown as a PT, I've noticed that the more in-depth and the more information I can get from a history, the better I can do for my patients. So it's very critical to get how the symptoms started, how they've evolved over the years, how you yourself feel about your pain. The more I can get out of you, the more I can kind of decide going into it what I want to check that day. I would say if I get a thorough enough history, I have a pretty good idea of what is already going on, and I can kind of prioritize like what's the best bang for our buck to focus on that day. So it's important if there's anything you think of when you're talking to the PT, you're like, I don't know if that's important, or I've had something 10 years ago, it's not going to hurt to bring it up. It's only a piece of information, whether it's relevant or not, we'll kind of decide as we go. But the more in depth that you can go, the better suited you're going to have within the PT world. So beyond the history is when we go into the actual examination part. So the movement screening, we want to see how you move. We want to check, obviously, the low back. So how do you bend forward? How do you bend to the side? But also in the PT world, we focus a lot on above and below the joint. So we want to check out your mid back. We want to check out your hips, knees. David is talking as far as watching people walk. Do you have any chronic knee issues, ankle issues? Are you stiff anywhere below? That's creating a lot of abnormal forces up into our low back. We want to take a look at functional movements. So are you sitting at a computer all day? What does that look like? Are you lifting all day? How does your lifting look? Squatting, getting down to the ground, getting down to your garden, just anything that you're doing on a consistent basis, how are you doing it? David talked a lot about breathing. Generally, we'll look kind of passively, like how are you breathing at rest? Are you breathing through your nose, through your mouth? How are your sitting posture? A lot of us are doing a good job because we have a back, but a lot of, like when I'm driving, I find myself sitting forward. If I'm at my computer or reading, we have those forward postures. This is what that looks like through you throughout the day. Then we go on to our manual assessment. So this is where we take a look, have you on your stomach, taking a look at the muscles, tendons, ligaments, what feels tight, what feels dysfunctional, what's painful for you. And joint mobility, this is where we'll kind of test out the actual lumbar vertebrae. There's those 5 that David talked about. Some of the thoracic, some of the hip, just how is the joint itself moving, whether it's with us moving it or how is it moving when you moving. We're watching the spine as you're like bending forward. And then strength testing. There's a lot of things we can test within the hips themselves. There's a lot we can test where David is talking about the PopCam theory. We want to see how is the diaphragm moving? How is your transverse abdominis, that kind of outside wall? How are you able to activate that? What they're finding with chronic low back pain is that we have a really hard time activating those small little local muscles. And so many of us go to the gym to work on core, which is a lot of that like 6-pack external muscles, but we're not really working that inner stability. We have a really hard time activating that, and it can be really frustrating because it's such a small muscle, which is a big component that we kind of work on going forward if you are dysfunctional in it. So that's kind of a really brief overview of the examination component as far as what we're looking at that first day. And a lot of times our examination it's happening every day that you guys are here. That first day is where we're getting a lot of it, but we're checking you out as you're evolving. If you're improving, if you're not improving, what is changing as far as the stiffness and the soft tissue integrity. So every visit that you have will have some form of examination, but that first day is obviously a lot more involved. Then the evaluation is the part that you don't always see, is us kind of taking all the information that we got, going through, interpreting what we found, recognizing patterns. I mean, at this point, we've been treating for a while, or however long David's been treating. You recognize patterns that people present somewhat similarly and how what has or hasn't worked for those people. And that's kind of a good way to start. But and then applying the research, which again, because low back pain is such a big prevalent thing in the United States, the research is probably more than most body parts at this point. So what did we find during that examination that we can use research for within that visit? Then making a game plan. And the big thing, especially for those that have persistent back pain, is making a game plan with you as a patient. It's not so much saying, hey, here's what we're going to do, but it's, hey, here's what I think we should do. What are your thoughts and how can we work together? You're most likely here because you have some episode or repetitive episode of back pain. I mean, if you've had one random episode, the likelihood of you being at this presentation is probably a little bit smaller. I'm guessing a lot of you have had back pain for years or keep having it over and over for some reason. And so the big thing with that is that you're creating a team with your PT. You're not just coming in for a few exercises and then you're out on your own, is that you have to make a game plan together going forward. And then just going over a brief overview of treatment. So like David said, this is very much tailored to the patient. What works for Jane doesn't always work for Joe. And what works for something that presentation-wise appears the exact same may work completely differently for those two patients. And that's why it's really important for those first few weeks to have some pretty consistent PT appointments so you can figure out what works for you and what doesn't work for you. The big thing too that a lot of people don't do with the PT aspect is just having open communication with your PT. If we give you some exercises, you go home, you feel like, hey, this seems to bother my back, it doesn't seem to be working for me, you just got to tell them that. It's not going to take offense to that we're trying to get you better. So if there's something that you feel like is not getting you better, we want to know that right away. A lot of it's going to be education. When we have this persistent pain, we want to know about and teach you about how important sleep is, which Evan might go into here in a second, but how important stress management is, how important activity is within tolerance. And then, of course, we're doing things like manual therapy. We're doing soft tissue massage, trying to get the muscles to loosen up, joint mobility to try to loosen the back up. We can do manipulations where we pop your back. I'm sure many of you have had dry needling, which is similar to acupuncture, but kind of a different thought philosophy, which is a really go-to for a lot of us as far as just waking some of the muscles up or even trying to calm some of them down. There's a lot of different things that we can focus on within dry needling. Then guided exercise. So again, this is where we're going to give you a few at the beginning. We're going to see, hey, is this working for that first week or two? Okay, it's not. Let's make some tweaks. Let's figure out what's going to work best for you. And then again, progressive home exercises. So the big thing with this, I mean, when you come into PT, you're coming once a week for 45 minutes. So that's the only thing that you're doing for your back during that week. I can be the best PT in the world. It's not going to make a difference. So giving you the exercises, you holding yourself accountable and doing them on a consistent basis. And then, like I said, that's what creates the team is I'll provide it, but you still have to do it. I can't do it for you. And a big thing with, before I go into the other treatments that Evan, the big thing with PT on the persistent pain type of things is that as much as I want to beat the PT drum that we can fix everything, you're going to be pain-free and never have back pain again, it's probably not going to happen. But like David said, our goal is to try to get you back to the things that you want to do. If you want to ski, if you want to do your gardening, is to make your pain something that's in the background of your mind rather than the forefront, where you can go do those things. Yeah, I overdid it. I had some back pain the next day, but I have these tools in my toolbox that my PT gave me that I can calm my back down, respond appropriately, get back out skiing in a couple days. Realistically, like I said, with a lot of this, if you've had back pain for 20 some years, you're probably still going to have it in some capacity, but we do have options to make it so it's not as painful, it's not as impactful within your daily life, and that you can go back to some of the things that you've been skipping because of you've been fear avoidant as far as the back pain. So beyond that, I'll kind of pass it over to Evan, who can go over a few options when PT either isn't helping as much as we want or things that can be adjuncts to PT and go from there.
Alrighty, thanks, Taylor. So yeah, I'm Evan, one of the newer therapists here at Excel. So we're gonna talk about some other interventions to kind of supplement either what we're doing or kind of give you more options if you've been in PT for a bit and we're not making the progress we're hoping to see. So a big one that we see often or utilize often is lumbar injections. I think this can be a really powerful tool in specific cases. So I feel like a big one that we see often is if you're dealing with those more sciatica or radiating leg kind of nerve type symptoms, where there's maybe some more specific locations where we know an issue is. These can be a really powerful tool for kind of getting pain under wraps. And a lot of these adjuncts can be a really nice segue to get you, better adherence or more tolerance to an active treatment approach via exercise, movement, and PT. Because there's a lot of times, when pain is just such a large barrier that any amount of motion or movement is just like we're not getting anywhere. So this can be a really nice tool in those cases to get that under wraps, and we can then kind of progress you back to those movements and more active things. Some other ones that we like to refer to, we've got some in-house massage therapists who are awesome that we utilize frequently. They've just got more time that we do to dedicate to those hands-on massage, which can be a really powerful tool for folks, as well as acupuncture. I hear about awesome acupuncturists in the Valley that people are utilizing. Both can be a really low-risk options for managing muscle guarding and pain. And again, a nice adjunct to this active treatment approach, which the research is pointing is a really important thing in the management of back pain. Somebody have any experience with massage therapy, acupuncture? Yeah, good experience, I have. Great. Beyond that, I think in specific cases, pharmaceutical or medication management can be a really important thing. When you look at the guidelines for back pain, that's not our first line recommendation, but again, there's times where pain is such a limiting factor that can be a really nice addition to get us moving easier or with more ease. As well as chiropractic care. Again, I see patients who are seeing other providers, chiropractic providers across the Valley, who get a lot of amazing value from that. And I think we try to collaborate with them and utilize them and kind of work with them a lot. They can be a really awesome adjunct to what we're doing as well. Beyond that, I think, even something as simple as yoga, which is an awesome combination of mobility, strength, exposing your spine to some different positions can be beneficial. I think that could be a really awesome tool as well. So let's talk about some self-help things that we can implement right now to kind of change our pain. So kind of David and Taylor mentioned this, but sleep hygiene is probably one of the most important things we can do for overall function. I think look at the stats and we spend like a third of our lifetime asleep or something like that. So certainly must be important if we're spending that much time doing it. When you look at the national recommendations for adults in the 18 to 60 range, they're recommending 7 and up hours. And then some just little tips you can implement to make your sleep a little higher quality. A consistent bed and wake time is a really important one. So if having some kind of schedule with your sleep so that you know when you're going to bed, you've got a routine, you know when you're going to wake up, and your body's just adapted to that, makes your sleep higher quality, as opposed to having kind of random wake and sleep times across the week. Making sure the environment in which you're sleeping in is cool, dark, quiet. Limiting technology before bed. Avoiding large meals and alcohol kind of right before bed. And then avoiding caffeine use later in the day. The half-life of caffeine is a lot longer than we think, and so it stays in your system longer than you think. And so, utilizing that earlier in the day as opposed to later in the afternoon. And then beyond that, just being regularly active and supplementing with a healthy diet. All those things that seem simple, but when you kind of stack them up, can be a really, really nice way to improve your sleep quality. So David, yeah, go for it.
Any research on that?
Yeah, as opposed to like how it impacts sleep quality in particular. Yeah, thank you. The question was, does the bed you're using impact your sleep quality? Is that? Yeah. Yeah, I don't know any off the top of my head. If you guys want to jump in.
I don't think there's any specific research, but I think it's much more based on patient comfort than anything else. So, I mean, the hard part is you can't just go buy a mattress, but I don't like this one, return it, and just keep doing that. I mean, some places I guess probably have that 30-day trial option, but it's whatever you feel most comfortable with is what's going to give you the best sleep. But there is no research that says you have to have a firm versus soft, or same with pillows even. It's a lot of questions that we get as far as like neck pain and stuff, is that whatever you feel like you are the most comfortable with is going to be the most successful when it comes to sleeping.
And I'm just going to use my own opinion here anecdotally. I think I would agree with that. Use what's comfortable for you that's going to make you more restful, more sleep better. I would tend not to do a very, very soft bed because I'm not sure that would support your spine very well. You may, because I like to keep the spine in neutral at night, whether you're on your side or on your back. You have a very floppy, very soft bed, you can end up in kind of a flexed position or a side bed position. So I tend to kind of steer my patients towards something that's a little firmer, but within their comfort realm. So I'm not going to push somebody to go get a firm bed. This is so uncomfortable, I can't even sleep. So on the firmer side is my opinion, but comfortable still.
I know you go to the mattress stores and you have your lay on the bed.
Right. I mean, spend a lot of time there. Get comfortable. That's what I would say.
Take a nap.
Take a nap. And I personally really like Tempur-Pedic beds. I'm not sure if anybody has those, but I have a Tempur-Pedic hybrid that many of my people I know like a lot. They're spendy, but yeah, take time. And like Taylor said, go to a place that will allow you to return it. Most good quality places that will sell you a bed will let you return it in exchange within a certain amount of time.
And people get hesitant spending more on a bed, but like you said, I mean, a third of your life, it's 20 to 30 years spent sleeping. So it's a worthwhile investment if it can improve your sleep hygiene.
I got a question. I've heard it before. They don't recommend bed rest if you have lower back problems. Now, sleeping is one thing, but during the day, they didn't really push to lay down and rest that way. Is that kind of a true statement?
100%, yeah. When you look at kind of all the national worldwide guidelines for back pain, yeah, we're not recommending like true bed rest as like a acute intervention. That's, I'd say, usually most relevant cases of like acute back pain. So, maybe it's your first episode or it was a very acute onset, pain's really high. We want to manage that with some amount of relative rest. And so, I'd say sleep is still a really important thing in that capacity. And like having, adequate recovery is important for our function as a whole. So we want to continue to enforce that or recommend that. But outside of that, we don't want to like spend all of our time resting. We want to still encourage some amount of movement, even if it's as simple as going for short walks and just kind of finding what's your tolerable, manageable entry point, and then kind of over time progressing from there. Does that answer your question?
I would
Okay.
support what
Yeah.
you're saying there. You want to move, we're made to move. When we're resting because of our low back pain in the middle of the day, I think you'd be much better off moving within your tolerance as opposed to being static and inactive. I love that term, motion is lotion, right, for your body. So moving will use your joints and make you more nourished and stronger. Being inactive is going to tend to take you in the opposite direction, especially with the persistent low back pain.
And yeah,
The adults 18 to 60 is not the demographic that you got in here.
that was the widest recommendation. It's a 16 up, I believe it's 7 to 8. Is what was on. Yeah, it was set, like they had 7 plus 18 to 60 and 7 to 8, 60 and up, I believe.
But at the same time, I think as we age, we struggle with sleeping. How many people here struggle with sleep? Like everybody's hands going up. So it's a tough thing, but as Evan's saying, sleep hygiene, there's things you could do to improve your sleep, like brushing your teeth hygiene. There's ways that you can approach your sleep that will actually improve your sleep. Those are the things that we kind of coach our patients on. And he gave you a couple of tips, like keeping your sleep within a specific period, right? It drives me crazy when people go, oh, Wednesdays I go to bed at this time, and then Tuesdays I go to bed at this time, and I'm always moving my window. If you move your window, your brain doesn't know when you sleep. That's why getting jet lag is such a problem, because you're on a major change of your sleep, and your brain is like, well, what's going on? Right? So you need to train your brain when to sleep. But I fully respect your question that it's hard. And even when you age, it's a little bit harder.
Going back to sleep position, is there a way at home to assess if you are properly, if you're a science sleeper in a neutral position? How do you assess that yourself?
Yeah, so the question was, is there a way for someone at home to assess their kind of sleep position? Are you in neutral on your side, or kind of where your sleep position is? Is that
Yeah.
okay? How do you know you're in neutral? Let's check that one out.
That's a great question. So, I mean, it should be like in standing, right? So when you're in neutral, you shouldn't be sleeping on your side and side bent one way or side bent this way. You can have your significant other look at your back and say, do I look neutral? But a lot of times, like, for example, if you have bigger hips and you go to lie on your side, you're going to tend to kind of slump down through your spine. So those people need to maybe sometimes put a little bit of something in here, very thin, maybe a pillow between your knees. So that is a hard thing to know in side lying. I don't know if there's a great answer to that question, but yeah, you generally want to, the wider the hips are, the harder it is to be in neutral and side lying. And you want to, a lot of people will sleep like in semi-prone. They'll sleep on their side and then they'll kind of twist their body. Well, that's certainly not in neutral. Are you one of these people? So putting a pillow between your knees to keep you on your side, even a body pillow, those pillows that are almost as tall as you, kind of like an extra person in bed, becomes an issue. But you can lie on your side and have one of these pillows that goes all the way down your feet and ankles and all the way up here. So it's underneath your head, between your knees. That's a good way to not roll into a twisted position.
How about sleeping on your stomach?
What's that?
Sleeping on your stomach.
I generally don't encourage sleeping on your stomach. I think it's hard to be in neutral. Maybe there's some extreme situations where that might be a good thing, but generally on your side or on your back is going to be best for your spine and your neck for that matter. Unless you have a hole in your bed.
I think I wake up every morning sleeping on my.
I'm not saying I don't do it sometimes too, but again, using that body pillow can be helpful because it can almost train you to not roll over as much.
I also sleep at hours now.
Congratulations. That's awesome.
Yeah, any last questions on sleep stuff? That was a good topic. I love it. Good stuff. All right. So moving on to, we kind of talked about stress and how it's important to manage that. And so I'd say, you know, stress and lack of sleep, nutrition, these are all the things that can not necessarily be a cause of your pain, but can definitely be a contributor into ongoing pain. And so David kind of mentioned like a sensitized nervous system where all of a sudden it's taking less and less stimulus over time to provoke this pain response. I think this is kind of a nice chart to illustrate this. And so on this axis, we've got stimulus intensity, right? And so a pain threshold is a very normal thing for us. Like there should be an amount of stimulus that provokes a pain response. You step on a nail, you should know about that. So usually there's a certain amount in this case, which is going to elicit that pain response. However, if you're dealing with persistent pain, over time, that threshold seems to work itself further back to where all of a sudden it's taken less and less intensity of a stimulus to evoke that pain response. And so naturally do more. It's kind of it's a tough cycle to break. And so stress can definitely be a contributor to this sensitization of your nervous system. And it's not necessarily something that's causing your pain. It's not the sole reason you have pain, but it can definitely be a reasonable, relevant contributor to why your pain is ongoing or persistent.
I could add to that real quick.
Yeah, go for it.
Use my dad as an example again. So he's had major low back pain over his lifetime. Major events of going into severe low back pain to the point of having to be taken to the hospital by an ambulance. Almost every time it was preceded by a stressful event in his life, something emotionally stressful. So it's exactly what he's talking about here. So it takes very little to kind of send you there when your stress is high. It doesn't take much to send you into one of these bouts of pain. So working on things to decrease your stress, and whole other topic.
Don't watch the news.
There you go. Watch the news. Yeah.
And obviously, we're not going to say there's a one-size-fits-all approach to managing that. And I don't know if any of us have a perfect answer for you on how to do that. And that's probably going to be a very individual thing. However, you know, sleep can be a really powerful tool for that. General activity, social engagement, like there's lots of things you can do in your life that are specific to you that, you know, probably branch beyond our capabilities to manage this. So beyond that, exercise is one of the best things we can do for low back pain. So this can look a lot of different ways. It's probably going to vary a lot based on your pain and what makes it worse, the flavor of it, the nature of it. So that's why we're kind of coming back to it's important to, you know, understand it, and seeing a PT can really help you, you know, get a better understanding of your pain so you can, you know, best exercise or best strengthen yourself to be resilient with that. Just giving you some like kind of brief overviews about what exercise could look like or what is beneficial. So we usually are, most of us using some amount of, you know, core or trunk strengthening. I think improving the, you know, as David was showing, we've got all this good muscle mass around our spine. And so improving the strength of that can definitely make our spine, our back more resilient and able to better handle what we want to do with it. So that can look like core specific. So just some examples, like I feel like a plank is a well-known example or variations of that. It could be rotational exercises, which your spine does. Stability work, kind of, you know, working on hip and trunk stability against movements. And then beyond that, we're supplementing that, also working on, you know, compound strengthening. So that would be, you know, motions are using multiple joints at once. So some common examples of that would be a squat or a lunge or a step up. You know, we're not necessarily isolating, going after one specific muscle like maybe we would be with more of the core specific trunk step, but we're utilizing a lot of these all at once, which is, you know, how we use our body in real life, is we're constantly moving around and using lots of things at once. So it's there's benefit in kind of training your body to utilize all of those at once and get stronger with that. Beyond that, doing some work for the hips can also be a really powerful tool. Obviously, the pelvis and hips are closely linked to our spine and low back. And so if we can, improve some mobility and strength there, that can be a really powerful tool as well. I think it's important to know that, our goal should be to progress these over time so that we're always, our goal should be to improve our capacity, our strength with these motions over time so that we're constantly asking our back to get stronger so we can better handle the demands of our life. So we're going to go into a few exercises. We'll have y'all get up and move out of the chairs. We've been sitting a while. About things we commonly give people for these that we can kind of try out on ourselves. Dave's going to jump into the first two here.
So important to note. It's going to hold it.
Oh, yeah.
It's important to note that not all exercises are for everybody, but we try to think of like 3 that we give almost everybody. So if any of you are my patients in here, you'll go like, oh, I recognize those. So the first that Evan is going to demonstrate is an open book right here on the floor with his pillow. So go ahead and do a left side lying open book to the right. This is safe for most people. So and you don't have to do this one, by the way, there's probably not enough room, but just kind of watch him here. So lying on your side with your knees flexed up a little further, hips flexed up. So you're about 90 degrees here, right? He's opening up. He's got a good pillow under his head and he's rotating his torso. Why is this exercise good? It's because your diaphragm and your rib cage become stiff over time and not allow you to move. And therefore, it puts excessive stress on your lumbar spine and kind of like what I say almost eats up your lumbar spine in a way. So this is a generally safe one. I have my patients do it 2 sets of 10 on either side. Thank you, Evan. So next one is a kneeling hip flexor stretch. Again, I give this almost to all my patients. So I'm going to demonstrate this. If anybody wants to try it, they can. But basically, you're going to be kneeling on one leg. So here I'm stretching my right hip flexors, my psoas, my iliacus, or my iliopsoas. Importantly here, because you'll see a lot of people do this, like I'm stretching my hip flexors. I feel 0 stretch in my hip flexors because I'm allowing my spine to go into lordosis, okay? So if I tuck my butt underneath me, like literally do a pelvic tilt, if I had a tail, it would go right between my legs. I bring this part of my lower rib cage and my pelvis together, and that right there stretches not only in my rectus femoris, my quadriceps, but I feel stretching right here. And that's oftentimes enough to get a stretch. So this is a very active stretch. It's kind of exhausting in a way because you got to hold this for 30 seconds and you do 3 on either side. And then lastly, you can do this in your chair. So I want you to try it. So we're going to do diaphragmatic breathing. We talked earlier about how we can breathe through our diaphragm. So putting your hands on your lower rib cage and sitting, and I want you to sit up relatively tall here. So if you start on your ribs with your hands and you run all the way down until you get to the very lowest ribs, those are your floating ribs, okay? And you want to feel rib all the way around from your fingertip to your web space to your thumb, okay? Now remember that video that I showed you? The hands around this way. There we go, okay. That video I showed you where you saw the descending of the diaphragm and it was spreading out the rib cage. So when you're really using your diaphragm to breathe, your lower rib cage will actually move out all the way around in circumference. Now, a lot of people talk about diaphragm breathing as being belly breathing. I don't love that talk. I mean, your belly does move, right? Because as you saw, if the abdominal contents is below that diaphragm, which is relaxed here and then contracts here, it's going to compress the abdominal contents and your belly will move out. But I want you to think more about, now that you have your hands in this position, and if you have trouble getting your shoulders there, you could even go like this if you want to, right? I want you to kind of breathe what we call low and slow into those lower ribs. So slowly breathing in through your nose. Breathe and feel this happen. Feel your hands kind of come apart a bit. And then as you exhale through your nose, you should feel your hands come back together, okay? So when you're breathing down low like that, you're using your diaphragm. And again, why do we want to use our diaphragm? Because when we have a good range of motion in our diaphragm, it loosens up our lower rib cage. It takes some of the stress off our lumbar spine, and it makes that top of the pop can more healthy. I'm showing it to you sitting because we're all sitting, but oftentimes I'll show it to patients lying down just like that. Yeah, so put a pillow under their head and they'll just lie there with knees bent and kind of work on that breathing. There's more to it, but that's just a simplistic way of talking about breathing through the diaphragm. Okay, so call to action. We'd love to see you. If you guys have, you want to see a PT, we'd be happy to see you. There's other PCTs in town that treat this. This is something that we specialize in. And I want to open up real quickly. We're kind of at the end, but to questions, if anybody has any burning questions. Yes? Do you need a doctor's referral to come in for physical therapy? It depends on your insurance. Medicare, you do need a referral. You kind of do and don't, okay? Legally in the state, you don't need one, right? But we find that we can get into trouble as PTs if we don't have a referral on hand. So we like to be very conservative. So if you have Medicare, we like to have a referral. Some of the private insurances outside of that require, but most of them don't. So Blue Cross Blue Shield of Montana, those kind of companies don't require referral. Great question. Yes? It's a sneaky question. Do you have to have a referral every time? Not always, but as I see my Medicare patients, if I haven't seen them for a while, it is a nice process to have an updated referral. Yeah. Yes? Yeah. You have a coworker, Danelle works here, that wears high heels and has low back pain. That's where it comes to the individual. I'd have to see that individual in a clinic and know. So I'm not going to, yeah, maybe. I'm not going to generalize and say that's true, but it can be true. Other questions? All right, so lastly, we are doing another presentation coming up December 3rd. This one's going to be on ski and snowboard injuries, mitigating risk and performance. Jason, one of our other owners here, and Kylie are going to be presenting that. So just kind of keep that in mind. You can scan it here if you want. And if anybody wants to stay and ask us personally just one-to-one questions, we're happy to do that. But we really appreciate you taking your time away. The Dodgers are probably winning right now, so we'll see. No, probably not.